So welcome to the Florida Digestive Diseases Update hosted by the Orlando Health Digestive Health Institute. I'm Shyam Varadarajulu and I'm a gastroenterologist at the Digestive Health Institute. So this is our fourth consecutive program. We started this event in 2022 after Digestive Diseases Week, and this is primarily done for the worldwide audience. So for those of you joining us online from across the world, we are in Orlando, Florida. We are in a restaurant with our colleagues and some of the gastroenterologists who we know for the last many years. And what we are going to do today is to present all the best findings of the abstracts from Digestive Diseases Week. This was presented in San Diego. So we have selected about 40 abstracts today for presentation across 4 different sections. And every year for hosting this event, we will invite a moderator. And the moderator for this year's event is Dr. Vivek Kumbhari. Dr. Kumbhari is a professor of medicine and chief of gastroenterology at the Mayo Clinic in Jacksonville. He did his graduate training at the University of Otago in New Zealand, and then furthered his career in medicine in Australia. He did his advanced fellowship at the Johns Hopkins. I was a faculty member at Hopkins for several years before he assumed the role of chief of gastroenterology. He was also the youngest chief of gastroenterology in the nation, taking a job before he turned 40. He's a very highly accomplished endoscopist, and he will moderate today's session. But most of all, I want to thank all of you from around the world for joining us today, and for our friends and colleagues from Orlando and Central Florida for being with us this evening. I also want to thank Olympus Corporation for sponsoring this event, which is not possible without their support. So Vivek, take it away.
Good evening, everyone, and welcome to those who are here in person and those around the world. You know, for those who aren't aware, I was sort of fascinated to learn a bit about the progress of the Orlando Health Digestive Disease Institute, and I wanted to share some numbers in the true Shyam style. You know, the growth rate, the CAGR of the Orlando Health Group with respect to patients served is 20% per year. 12,000 procedures were performed in the last year. Shyam and his team have grown the group to 250 staff, 40 physicians, 40 APPs, and there's 8 campuses. And so, you know, in my opinion, the Orlando Health Digestive Disease Institute is a premier GI institute in the country. And this is based on lives touched, 50,000 lives touched annually, contribution to the field through research, particularly high quality research, the hard stuff. Education is demonstrated by events like this, other CME events, and perhaps most importantly, you know, his commitment to the new generation and the introduction of the GI fellowship at Orlando Health is something that is hard to do, but again, a testament to building the future. You know, I love that the ethos of this institute is really one that prioritizes the patient and referring provider experience. And just mingling with many of you tonight, you know, some comments I've heard as you've spoken to the faculty at Orlando Health, like, thank you for always being available. You know, thank you for helping me with that difficult patient. And this is really special and heartfelt, I'm sure. And I'm actually delighted to see that, you know, what was initially a center focused on sort of being the preeminent interventional endoscopy group has now grown into an institute that encompasses all the subspecialties of gastroenterology and hepatology. And, you know, special congratulations to all the Orlando Health team on the opening of the new facility. I know that it's sort of your commitment to serve your patients and perhaps as important, to serve your staff that inspired the design of the unit. And on a very personal note, you know, despite not directly working for Shyam, he's one of the 5 foremost people who've influenced my life, both professionally and personally. You know, for those striving to contribute to our field, you know, I encourage you to consider Shyam's passion, persistence, and resilience as an example. You know, they say to build something special, you have to do something special. And I think this is the Orlando Health Institute is an example of that. And I think hard work always pays off as long as your event horizon is long-term. And I think that's what we've seen here with the team. And for those who've recently joined the Orlando Health Digestive Disease Institute team, I do hope you feel very proud of this milestone, as I know, and I think we all know, that the benchmark to meet the criteria to join such a group is incredibly high. So as mentioned, you know, for today's 40 abstracts, they've been sort of particularly chosen to challenge the status quo and to encourage you to constantly reassess, you know, what is best practice. These abstracts don't necessarily mandate a sudden change in how you look after your patients, but I hope they at least spark some curiosity. And so to kick off, I'm going to ask Sunina Nathoo to speak first. She's from she did a medical school and residency at UF Gainesville, GI fellowship at Baylor College of Medicine in Houston, and she's presently an attending physician and hospitalist at the Orlando Health. That's all yours. Thank you.
Thank you for the intro, and thank you for being here, everybody. I'm going to kick off the general GI section, the update. These are 10 abstracts that have been selected. Our first abstract is GLP-1 receptor agonists rarely cause de novo acute pancreatitis, but may cause serum lipase elevations of unclear clinical significance. This study was to try to investigate the true causal relationship between GLP-1 receptor agonist use and acute pancreatitis, adjusting for known risk factors and exploring potential underlying mechanisms. The methods, patients were selected from a database, pancreas database nationwide. Patients were identified with the markers of lipase greater than 3 times the upper limit of normal. And they were identified also for GLP-1 receptor agonist use concurrently from December 2020 to October 2024. Relevant clinical history, laboratory, and imaging data were reviewed. In patients with a confirmed acute pancreatitis and history of GLP-1 receptor agonist use, evaluation was done to identify what the cause of acute pancreatitis or the etiology was. Of the patients that were identified, there was a total of 2,600 patients with elevated lipase levels. 53 of these were receiving GLP-1 receptor agonists concurrently. 40% of those patients had imaging changes consistent with acute pancreatitis, while 32 had a normal pancreas despite the elevated lipase levels. Among those with acute pancreatitis on imaging, other etiologies were identified in the majority of patients. And these were the etiologies that we usually encounter: gallstones, hypertriglyceridemia, alcohol, trauma, genetic, and post-ERCP. No clear etiology was identified in 6 patients, and these were potentially attributed to GLP-1 receptor agonists. They also looked at CT imaging within 48 hours of lipase elevation. And they did find in these patients, of 5 of them with the imaging available, that there was an increase in pancreas volume in 80% of the patients with hyperlipemia. This was suggestive of acinar cell hyperplasia. In short, only a small fraction of patients with GLP-1 receptor agonist use and lipase elevation had confirmed imaging findings of acute pancreatitis. This leads us to believe that hyperlipemia may be due to acinar cell hypertrophy or hyperplasia, and this may warrant further investigation to determine if this can predict a subset of patients who are at risk of developing acute pancreatitis. Our next abstract is the safety and efficacy of inebilizumab in IgG4-related disease in participants with pancreatic and biliary involvement. These are results from a phase 3 mitigate trial. Inebilizumab, which is INIB for short, is an anti-CD19 antibody that results in rapid and durable B-cell depletion, and it's being used as a treatment for IgG4-related diseases. Mitigate was an international randomized blinded placebo-controlled phase 3 trial to evaluate safety and efficacy. This was a post hoc subgroup analysis of the patients with pancreaticobiliary involvement. Patients were selected if they had a history of at least 2 organ involvement and an IgG4-related disease flare that required steroid use. Patients were randomized in a 1-to-1 fashion to INIB or placebo, and they were treated on day 1, 15, and week 26 of a 1-year randomized control period. Steroids were subsequently tapered at the end of week 8, and all other immunosuppressive medications were prohibited. There were a total of 135 patients. 52% had a history of pancreatic involvement, 32 with bile duct involvement. INIB did decrease the flare risk, which was the primary endpoint relative to placebo in the pancreas group. Interestingly, there were no flares in the bile duct or combination group compared to flares 12 and 11, respectively, in the flare groups, in the placebo group, The proportion of patients achieving flare-free, treatment-free remission were higher in the INIB group when compared to placebo for pancreas, biliary, and combination groups, so all groups involved. Steroid use was reduced in INIB, and the serious adverse events associated with INIB included hyponatremia and mastopathy, but these were very low numbers. There were no deaths involved. In conclusion, CD19 targeted B-cell depletion therapy may be effective and safe in patients with pancreaticobiliary IgG4-related disease, as seen in this mitigate trial. Our next study is the comparative effectiveness of PCABs versus PPI for upper GI bleeding. This was a US multi-center study. There's limited data about the comparative effectiveness of PPIs versus PCABs, which came to the US market within the last year in preventing recurrent GI bleeding in patients with peptic ulcer disease or GERD with esophagitis. This was a retrospective multi-center cohort study that was conducted using the TriNetX database. Adult patients who were admitted with GI bleed due to peptic ulcer disease or GERD with esophagitis were either discharged on PPI or PCAB. One-to-one matching was performed for these cohorts. The primary endpoints were recurrent GI bleeding and healthcare utilizations within 180 days of discharge. The study included 166 patients that were balanced in both arms. At 6 months compared to PPI, PCABs were associated with a significantly lower risk of recurrent GI bleeding, all-cause ER visits, and all-cause hospitalizations. This leads us to believe that PCAB therapy was associated with significantly better outcomes compared to PPI in preventing recurrent GI bleeding and reducing healthcare utilizations at 180 days in patients with peptic ulcer disease and GERD with esophagitis. Of note, they did exclude patients who had cirrhosis and AVMs, so it'd be interesting to see if these studies, if this study and their findings were also found in other causes of GI bleeding. Our next study is the yield of interval fecal immunochemical testing following colonoscopy. This were results from the large nationwide veteran database. As we know, current guidelines advise against an interval FIT or FIT testing within 10 years of a negative colonoscopy, but oftentimes it's done inadvertently or inappropriately prior to the recommended next screening, so an interval FIT. There's currently no data on the outcomes of interval FIT or how to handle this clinical scenario. Data was obtained from the VA system using SNOMED codes and natural language processing. Patients who underwent colonoscopy by FIT within 10 years were included. Polyps on the index colonoscopy prior to FIT and the post-FIT colonoscopy were identified. Advanced adenoma was defined as adenoma with high-grade dysplasia, tubulovillous adenoma, or colorectal cancer. The primary outcomes were the prevalence of IFIT, predictors of positive IFIT, and subsequent findings on the follow-up colonoscopy. A very large number of patients were identified, 4.8 individuals who underwent colonoscopy. Of these patients, almost 11 had an IFIT, and of those, 15.6% were positive. Index colonoscopy was negative in 60% of IFIT patients versus 65% of IFIT negative patients. Of the 82,000 patients who had a positive IFIT, 50% underwent follow-up colonoscopy. The median time to that colonoscopy was about 2.7 months. Advanced adenoma was detected in 8% of patients and colorectal cancer in 3% of patients. Independent risk factors of advanced adenoma were those with positive IFIT, were male gender, age greater than or equal to 50, and advanced adenoma on index colonoscopy. The conclusions of this study are that the prevalence of IFIT was relatively high for this closed system, which in turn was positive in almost 16% of patients, with advanced adenoma detected in 8% and colon cancer in 3%. This suggests the yield of an IFIT is high and may be useful in screening programs. This is another study about colonoscopy. Colonoscopy adherence varies by indication and travel time. This is another VA study. This study aimed to determine whether FIT adherence is affected by travel time. They hypothesized that FIT adherence would not be impacted by travel time relative to colonoscopy for a FIT test, as that can be done at home non-invasively. The impact of travel time on colonoscopy completion would be less relative to screening colonoscopy. The methods, veterans were identified 50,000 that were due for colon cancer screening, and they're randomized in a one-to-one fashion to either FIT or colonoscopy. The travel time to the VA was gathered based on questionnaires. The overall adherence as a function of the randomized test, colonoscopy or FIT, and travel time was examined. Logistic regression examined the impact of travel time on colonoscopy completion within 6 months by indication, whether it was screening or after a positive FIT. The results showed that travel time had no impact on FIT adherence as suspected, but significantly reduced screening colonoscopy adherence. Among FIT positive patients, 74% underwent colonoscopy, a completion rate that was significantly higher than screening colonoscopy as suspected. In the two models, logistic regressions that were performed, increasing travel time did significantly reduce screening colonoscopy completion, but was not associated with colonoscopy completion for FIT positive patients, again, as suspected. Just as an aside, the rough median travel time to get the colonoscopy was about 30 minutes. The conclusions of the study was that travel time significantly impacts screening colonoscopy adherence, but not FIT adherence, nor colonoscopy completion following FIT positivity. Patient education is key, as they found that poor patient education was the reason for poor adherence for both FIT and for colonoscopy. Switching gears a little bit, this study is a food intervention trial. Dried fruit increases stool weight and stool frequency in chronic constipation, a randomized placebo-controlled fruit intervention trial. This study was to investigate the impact of dried fruit, which contains fiber and sorbitol. Fiber increases stool bulk, can change transit times. Sorbitol has an osmotic effect. Fruit juice, which has sorbitol but no fiber, and a fruit-flavored placebo on the symptoms of constipation. Participants were identified based on Rome 4 criteria for functional constipation and were randomized to one of three arms. Arm 1 received the dried fruit, which was 90 grams of 30 each of prunes, raisins, and apricots. The second arm was fruit juices from the same fruits, and the third was a cordial placebo of water and sugar with the same fruit flavorings. The primary outcome was change in stool weight based from a 7-day total stool collection. All I can say about that is, wow, that they did that. Clinical outcomes included stool frequency and consistency, GI and constipation symptoms, and then overall quality of life, like other studies that look into constipation and IBS. The results of the study, there were 150 patients that were included with a female preponderance. The mean age, of the patients were 34 years. A change in stool weight was significantly different between the groups, the highest being with dried fruit, followed by fruit juice, and the lowest for placebo, with the significant change when you look at dried fruit versus placebo. Compared to placebo, there were significantly greater increases in complete and spontaneous bowel movements for dried fruit. There was also greater quality of life data between dried fruit and placebo. Overall, dried fruits containing both fiber and sorbitol were effective for constipation. They are doing more analyses using SmartPill and microbiome, but those results are underway and not yet available. Our next study is another constipation study. It's a multi-center, double-blind, randomized, placebo-controlled trial to evaluate the efficacy and safety of elobixibat in treating patients with chronic constipation. Elobixibat is an ileal bile acid transporter inhibitor. So I think it provides more water getting into the colon as a treatment for chronic constipation with a different mechanism of action than the other osmotic laxatives that we have available. This was a multi-center randomized double-blind placebo-controlled trial that compared 12 weeks of the drug elobixibat with placebo in patients with chronic constipation. And again, this was based on Rome 4 criteria. Subjects were randomized to the drug or placebo in a 2-to-1 allocation. Primary endpoints were similar to the previous study with complete spontaneous bowel movement response, and this was during a 12-week treatment period. An additional 4 weeks of follow-up was applied to observe withdrawal and possible rebound phenomenon. This study included 361 patients that were randomized, again, 2-to-1, so there were more patients on the elobixibat or the drug. Overall, complete spontaneous bowel movement response rates were significantly higher with the drug compared to placebo throughout the study during each week, but not during the last week of follow-up or last visit of follow-up. Mean stool consistency scores were also higher for the drug, but not during the follow-up period. So I wonder if there's some sort of change in the body or reequilibration that occurs. There was no significant differences in safety assessments as well. Elobixibat could significantly improve bowel function and reduce the severity of symptoms in chronic constipation when compared to placebo, and does give us a different mechanism of action for chronic constipation. This is another study, but looking for IBS diarrhea, low and high dose rifaximin versus low dose rifaximin combined with N-acetylcysteine for treating diarrhea predominant IBS. This was a double-blind randomized proof of concept trial. The aims of this study were to compare rifaximin with rifaximin plus NAC alone for the treatment of diarrhea predominant IBS after rat studies have shown that there have been changes. Patients were selected meeting Rome 4 criteria, and they did get a 3-gas breath test performed. And they were randomized double-blind to rifaximin with the standard dose, low-dose rifaximin, or low-dose rifaximin with N-acetylcysteine for 14 days. Patients then underwent a repeat breath test and were followed for 4 weeks after therapy cessation. Other markers that they evaluated included daily symptom reports, stool images, also very interesting. Stool sequencing for microbiome were also collected throughout treatment and at follow-up. 45 patients were enrolled, 15 per arm or group with an intention to treat analysis. This showed that low-dose rifaximin and NAC resulted in greater reduction in stool frequency compared to rifaximin alone, and it was more evident using AI to look for Bristol stool scale, stool fragmentation, and consistency. This was also durably seen with improvements with pain, bloating, and diarrhea. They did breath test, which I think was interesting because we typically don't do that in clinical practice with IBS diarrhea patients. And they found that there was a significant reduction in hydrogen sulfide, which was statistically significant. The conclusion of the study is rifaximin with NAC was superior to rifaximin alone, with improvement in bloating, diarrhea, pain. And there was no microbiome disruption observed despite the decrease in hydrogen sulfide on the breath test. Our next study is switching gears, more gastric interventional study, a combination of gastric fundus mucosal ablation and endoscopic sleeve gastroplasty. And these were results from 2 first-in-human studies. So endoscopic sleeve gastroplasty achieves roughly a 15% total body weight loss at 12 months, but falls short of a vertical sleeve gastrectomy. This may be due to the retention of preserved fundic accommodation, early hunger return due to hormonally active gastric mucosa. So it's postulated that if you take ablation of that tissue and you add it with endoscopic sleeve gastroplasty, that you can maybe recapitulate a ventral sleeve gastrectomy. This was the 2 first in-human studies to determine whether you can take a staged approach where you ablate and then you do a endoscopic gastroplasty, or a single session combining these techniques, and then you compare that to a vertical sleeve gastrectomy. There were 2 different arms. In Ablate 1, patients underwent the fundic ablation at baseline, and then they had an endoscopic sleeve gastroplasty at month 6. In Ablate Weight 2, they had both together spontaneously at baseline in a single session. Gastric fundic mucosal ablation was performed using hybrid APC to ablate the gastric fundal mucosa. And the primary outcome evaluated was total body weight loss percentage at 12 months, and they also looked at safety and feasibility. The results, patients included, there were 20 total, 10 in each arm, with a BMI of 40 plus or minus 5. The combined procedure duration, scope in and scope out, was 102 minutes. In the Ablate Weight 1 group, so these were the patients that underwent ablation and then subsequent staging. So they underwent ablation and then gastroplasty later on. They had total body weight loss of 7% at 6 months, and this increased subsequently all the way to 22.5% at 12 months. And Ablate Weight 2, so this was the combined procedure where they underwent the ablation and gastroplasty at the same time, the percentages were higher, and they reached 23% at 12 months. There were no adverse events reported in this study. In conclusion, gastric fundic mucosal ablation is feasible and a safe adjunct to endoscopic sleeve gastroplasty, and interesting, resulted in similar weight loss to a vertical sleeve gastrectomy through a non-surgical outpatient safe procedure. Very interesting. Our final study is the impact of endoscopic gastric remodeling on hepatic decompression and MASH cirrhosis with portal hypertension. There is emerging evidence that highlights the effectiveness of endoscopic gastric remodeling, a minimally invasive weight loss procedure, and improving MASH cirrhosis and reducing portal hypertension, which is a key risk factor for hepatic decompensation. This study compared the time to hepatic decompensation in patients with MASH cirrhosis and portal hypertension who underwent endoscopic gastric remodeling plus lifestyle modification versus lifestyle modification alone, which is what we usually tell our patients. This was a retrospective single center study that evaluated patients with MASH, compensated cirrhosis, and portal hypertension. Interventional group underwent endoscopic gastric remodeling in addition to lifestyle modification, while the control group underwent lifestyle modification alone. The primary outcomes were time to hepatic decompensation between the two groups, and the secondary outcome was time to major adverse liver outcomes between the two groups. There were a total of 36 patients that were included. 12 underwent endoscopic gastric remodeling and lifestyle modification, whereas the control group, 24, did lifestyle modification alone. Hepatic decompensation occurred in 33% of patients in the lifestyle modification group, with median time to decompensation being 24 months. Interestingly, there were no patients in the endoscopic gastric remodeling group that experienced a decompensation. There were also similarly major adverse liver outcomes that occurred in, again, the same 33% of patients in the lifestyle modification group with the same median time to decompensation. There were no patients in the endoscopic gastric remodeling group that experienced a major adverse liver outcome. In conclusion, endoscopic gastric remodeling significantly delays hepatic decompensation in patients with compensated MASH cirrhosis and portal hypertension compared to lifestyle modification alone. An interesting thing to add to our arsenal for these patients moving forward. So just some take-home points from these slides. Number one, only a small fraction of patients on GLP-1 receptor agonists develop clinical acute pancreatitis. Therefore, it's important to look for other etiologies before ascribing GLP-1 receptor agonists as the causative agent. PCABs appear to be superior to PPIs in preventing ulcer bleeding and for the treatment of reflux esophagitis. A positive FIT test appears to improve patient compliance for undergoing screening colonoscopy. In patients who have a positive interval FIT, if the index colonoscopy has shown advanced adenomas, then a repeat colonoscopy may be considered, especially if they have risk factors such as male gender, age greater than or equal to 50, or the presence of an advanced adenoma on the previous colonoscopy or index colonoscopy. Ilobixabat, which is an ileal bile acid transporter inhibitor, showed promising results in clinical trials for treating patients with chronic constipation. We also discussed the addition of dried fruit, which was rich in fiber and sorbitol, as a non-medical or food alternative. Finally, rifaximin with NAC was superior to rifaximin alone, with improvements in bloating, diarrhea, and pain for diarrhea-predominant IBS. And lastly, ablation of the mucosa and gastric fundus in conjunction with an endoscopic sleeve gastroplasty appeared to be as effective as a vertical sleeve gastrectomy. Endoscopic gastric remodeling improves clinical outcomes in patients with MASH cirrhosis and portal hypertension. Thank you.
Thank you very much. That was excellent. You know, it's kind of fascinating to wonder what these GLP-1 receptor agonists are doing to the pancreatic islet cells. You know, the sort of constant and persistent, you know, sort of super drive that these cells go under sort of make you wonder if there is you know, something that we need to be worried about. It was interesting to learn, and perhaps relevant for all of us. You know, the patient experience matters so much as we think about the best tests, particularly screening tests that these patients want to undergo. It seems even driving 30 minutes maybe a little too far. And so I think we do need to start thinking as a field as to how we can bring some of these tests to the comfort of their home. You know, I think the chronic constipation is clearly a disease with an emerging incidence. And rather than patients sort of subjecting themselves to perhaps a healthy diet and lifestyle, that they'd much rather swing towards medications. And I think that's a reality and something that we'll have to know more about. I think the endoscopic weight loss therapies now are able to approach, you know, surgical level weight loss. And again, something to think about as we manage our patients with obesity. And so next up is someone very well known to you all, Dr. G. Bang, who at any institution would be a full professor of medicine and perhaps at some even a named professor. So very happy to have her speak here. She's from the University of College London. Her residency was at UAB. And her fellowship was at the Flora Hospital, Orlando. And she's also spent some time in my hometown at the University of Sydney. So presently, she's obviously an interventional endoscopist, but also the Director of Clinical Research here at Orlando Health. So G, teach us about endoscopy.
Hello, good evening, everyone. So we'll be reviewing abstracts on endoscopy from DDW. Our first study is the SHARP trial. It is the randomized trial comparing minor sphincterotomy with sham procedure in patients with idiopathic acute recurrent pancreatitis and pancreas divisum. So again, this is a sham-controlled randomized trial to measure the impact of minor papilla endoscopic sphincterotomy on the risk of subsequent acute pancreatitis. This is a sham-controlled, single-blind, multi-center randomized trial, and inclusion criteria were patients with history of at least 2 documented episodes of idiopathic acute pancreatitis, at least 1 within 24 months prior to randomization, and pancreas divisum confirmed by MRCP. Patients were randomized to undergo EUS with sham ERCP, where the pancreatic stent was placed into the duodenal lumen, or EUS with minor papilla sphincterotomy and placement of a prophylactic PD stent. The primary outcome was development of acute pancreatitis defined as a time to event measure, and subjects were followed for a minimum of 6 months and up to 48 months. 148 patients were randomized, 75 to the minor papilla sphincterotomy and 73 patients to the sham ERCP procedure. Patients had a median of 3 acute pancreatitis episodes prior to randomization, and the median age at first acute pancreatitis episode was 51 years. During a median follow-up of 33.5 months, 34.7 patients in the minor papilla sphincterotomy arm had an acute pancreatitis event, compared to 43.8% in the sham arm. The incidence rate ratio was 0.23 for minor sphincter papillotomy. I'm sorry, and 0.277 for sham, meaning that acute pancreatitis episode frequency after randomization was reduced in both study arms. There were no differences in incidence of chronic pancreatitis, diabetes, and exocrine pancreatic insufficiency. So in conclusion, unfortunately, this randomized trial shows that minor papilla sphincterotomy does not reduce the risk of acute pancreatitis or related sequelae in patients with acute recurrent pancreatitis and pancreas divisum. Our next study is a randomized trial comparing US-guided biliary drainage, so that's choledochoduodenostomy, and ERCP in patients with malignant distal biliary obstruction. This is a randomized trial from Italy, where they compared outcomes of EUS-guided choledochoduodenostomy and ERCP as the primary modality for malignant biliary decompression. So this was a multi-center randomized trial of consecutive patients with obstructive jaundice due to malignant distal biliary obstruction, where the bile duct diameter was at least 15 millimeters. Patients were randomized to receive either US-guided choledochoduodenostomy or ERCP as a primary biliary drainage method. This was a superiority trial with acute pancreatitis post-procedure as the primary outcome. 220 patients were enrolled in the study. US-guided choledochoduodenostomy group had a lower risk of post-procedural acute pancreatitis with post-ERCP pancreatitis rate of 1.8% versus 7.3% in the ERCP group. Technical success was achieved in 94.6% of the EUS group and was quite low in the ERCP group at 78.9%. With a mean procedural duration that was shorter for EUS at 13.5 minutes versus 25 minutes for ERCP. There were no differences in adverse events, clinical success, stent patency, or overall mortality. So in conclusion, US-guided choledochoduodenostomy was considered superior to ERCP in this randomized trial at reducing post-procedural acute pancreatitis risk, and they also were able to achieve a higher technical success with comparable clinical efficacy. So these results support the use of US-guided choledochoduodenostomy as a primary approach in patients with dilated bile duct and obstructive jaundice. Our next study is a randomized trial of endoscopic transpapillary gallbladder stenting. This is when stents are placed into the gallbladder during an ERCP procedure versus EUS-guided gallbladder drainage in high-risk surgical patients. This is a randomized trial from Thailand where they wanted to compare the long-term effectiveness of these two techniques in patients with acute cholecystitis but were high-risk surgical candidates. So patients with acute cholecystitis who were considered high risk for surgery were randomized to either ERCP and transpapillary gallbladder stenting versus EUS-guided gallbladder drainage. In the ERCP group, patients underwent placement of 7 French by 15 centimeter double pigtail plastic stents. And for EUS-guided gallbladder drainage group, either luminal metal stents or fully covered metal stents were utilized with double pigtail plastic stents for anchoring. The primary outcome was the incidence of recurrent acute pancreatitis during follow-up. 80 patients were enrolled in total, 41 patients to ERCP and 39 patients to EUS. The ERCP had a lower technical success than EUS at 87.8% versus 100%, with similar clinical success, which was 100% for both groups. The transpapillary stenting was unsuccessful due to an acute cystic duct angle in 3 patients, cystic duct stone in 2 patients. The procedure-related adverse events did not differ between the 2 groups. The rate of recurrent acute pancreatitis or acute cholecystitis was higher in the ERCP group compared to the EUS group at 17 versus 2.6%. When they performed a survival analysis using a Kaplan-Meier method, they revealed a significantly higher rate of recurrent acute cholecystitis in ERCP compared to EUS during the median follow-up of 383 days. In conclusion, in high-risk surgical patients with acute cholecystitis at 1 year, EUS-guided gallbladder drainage was able to provide a significantly lower recurrence rate of acute cholecystitis and higher technical success than ERCP and transpapillary gallbladder stenting. Our next randomized trial is from our group. We're comparing EUS-guided gastrojejunostomy with surgical gastrojejunostomy in patients with malignant gastric outlet obstruction. So although surgical gastrojejunostomy is the standard method for palliation of malignant gastric outlet obstruction, EUS-guided gastroenterostomy is being proposed as a novel alternative approach. We wanted to compare both methods and whether clinical outcomes for EUS could be superior to surgery. This was a multi-center randomized trial. We enrolled patients from 3 different countries, United States, India, and Germany. And we enrolled patients with malignant gastric outlet obstruction who had unresectable pancreatic biliary or gastroduodenal malignancy with a symptom, with a GU symptom score of 1 or 0, which means they can only tolerate a liquid diet or NP or couldn't tolerate any liquids at all. Patients were randomized to receive either EUS gastroenterostomy or surgical gastrojejunostomy. The primary endpoint was a composite endpoint where we combined the inability to tolerate solid diet prior to hospital discharge, need for reinterventions or supplemental nutrition, and procedural-related adverse events. 74 patients were enrolled in total, 38 patients to EUS, 36 patients to surgery. The primary endpoint, which was a composite of not being able to tolerate a solid diet, need for reinterventions, supplemental nutrition, and procedure-related adverse events, occurred more commonly in surgery at 38.9% compared to 7.9% in EUS. Also, more patients in the surgery cohort could not tolerate a solid diet at discharge, required more reinterventions, and also more patients required supplemental nutrition post-procedure. The procedure-related adverse events were similar between both groups at 2.6% and 2.8% respectively. In conclusion, in patients with malignant gastric outlet obstruction, EUS-guided gastroenterostomy was superior to surgical approach, as fewer patients had difficulty in tolerating oral intake of soft diet at hospital discharge and required less reinterventions and supplemental nutrition. The next randomized trial is by Saito et al. This is a study from Japan. These authors compared plastic and luminal metal stents for EUS-guided drainage of pancreatic pseudocysts. So EUS-guided drainage is the standard approach for patients with symptomatic pancreatic pseudocysts, but the optimal stent remains unclear. This is called a WANDER-02 trial, where they wanted to see if plastic stents would be non-inferior to luminal metal stents. This is a non-inferiority randomized trial comprising 80 patients across 26 centers in Japan. Patients were randomized in a 1-to-1 ratio to undergo either drainage using plastic stents or luminal metal stents. The primary outcome was clinical success, defined as a reduction in the size of the pseudocyst to less than 2 centimeters, with improvement in inflammatory markers within 6 months of EUS-guided drainage. Secondary outcomes included technical success, adverse events, recurrence of pseudocysts, and mortality. 80 patients were enrolled in total. The clinical success of the plastic stent group was considered non-inferior to the luminal metal stent group at 97% for plastic stents and 95% for luminal metal stents. There was no significant difference in technical success, procedure-related adverse events. Stent migration was the most common adverse event in the plastic group, and bleeding was the most common adverse event in the metal stent group, with 2 out of the 3 bleeding being considered moderate or severe. There was no significant difference in terms of recurrence rate after clinical success was achieved. So in this randomized trial from Japan, it shows that plastic stents are non-inferior to luminal metal stents for EUS-guided drainage of pancreatic pseudocysts. Our next study is comparing EUS-guided liver biopsy and portal pressure gradient measurement compared to transjugular approach. This is another randomized trial. The patients were randomized to undergo either EUS-guided or transjugular route for portal pressure gradient measurement and liver biopsy. The primary endpoint was the proportion of high-quality liver biopsy specimen with consistent portal pressure gradient measurements. 58 patients were randomized in total, 29 patients to EUS and 29 patients to transjugular route. The primary endpoint was met in 24 patients, that's 83% in the EUS group, 41% only in the transjugular group. The mean procedure duration was 20 minutes for EUS, significantly longer at 49 minutes for transjugular group. The mean total aggregate length for EUS, again, was significantly greater in the EUS versus transjugular arm, and complete portal tracts per specimen was also significantly better at EUS than transjugular arm. Consistent portal pressure gradient measurements were also obtained in 89.7% for EUS and only 59% for transjugular. So this randomized trial shows that EUS is superior to transjugular route for simultaneous acquisition of high-quality liver biopsy and consistent portal pressure gradient measurements. Our next randomized trial is looking at different solutions that can be used when performing endoscopic resection of large colon polyps. This is by Paul et al. And the purpose of this randomized trial was to examine the safety and efficacy for performing endoscopic mucosal resection with normal saline or a viscous solution. Patients with polyps that were at least 2 centimeters in size were randomized to cold or hot EMR, and then to submucosal injection with a viscous solution, where they were allowed to use Elaview, hydroxyethyl starch, Everlift or Orise, or normal saline with a contrast agent mixed in. Low-dose epinephrine was added to all injection solutions, and the primary outcome was the incidence of any severe adverse event. A total of 660 patients were randomized. They found no difference in overall incidence of severe adverse events at 4% for viscous solution, 2.4% for normal saline. Post-procedure bleeding was more frequent with viscous solution at 3% versus only 0.6% for normal saline. And a non-significant difference was seen for perforations. They had 1 perforation of viscous solution group and 4 perforations in normal saline group. Polyp recurrence rate was similar and technical outcomes showed that viscous solution required less injection and afforded longer lifting. The overall performance of normal saline was inadequate or poor compared to viscous solution as judged by the investigators. In this randomized trial, severe adverse events and recurrence rates was similar following EMR of large colon polyps using viscous solution or normal saline with contrast. However, bleeding was more frequent with viscous solution, while perforation occurred numerically more with normal saline, and technical outcomes also favored viscous solution. So again, minor papillary sphincterotomy does not reduce the risk of acute pancreatitis or related sequelae in patients with acute recurrent pancreatitis and pancreativism, which is unfortunate. Secondly, EUS-guided choledochondriogenostomy is superior to ERCP in reducing post-procedural acute pancreatitis risk with improved technical success and comparable clinical efficacy in patients with common bile duct diameter of at least 15 millimeters. In high-risk patients with acute cholecystitis at 1 year, EUS-guided gallbladder drainage was associated with lower recurrence and higher technical success than endoscopic transpapillary gallbladder stent placement. In patients with malignant gastric outlet obstruction, EUS-guided gastroenterostomy was superior to surgery, as fewer patients had difficulty in tolerating oral intake of soft diet at hospital discharge and required less reinterventions or supplemental nutrition. Plastic stents are non-inferior to metal stents for EUS-guided drainage of pancreatic pseudocysts. EUS is superior to transjugular approach for high-quality liver biopsy and more consistent portal pressure gradient measurements. And serious adverse events and polyp recurrence rates were similar following EMR of large colon polyps using either viscous solution or normal saline with contrast. And while bleeding was more frequent with viscous solution, perforation occurred numerically more with normal saline. However, the overall technical outcomes were in favor of the use of viscous solution. So I think here you pick your poison, bleeding or perforation. All right, thank you so much.
Thanks, G. I mean, clearly the interventional EUS is now prime, and it looks like it's becoming standard of care that EUS-guided biliary drainage for patients with biliary obstruction and dilated bile duct. I mean, should that be our new sort of primary procedure? We saw EUS-guided drainage of the gallbladder being preferable to ERCP. We saw EUS-guided drainage of EUS-guided gastroenteric anastomoses now actually being better than a surgical anastomosis. And so I think that should be the go-to. And then I think as we went along, we saw some nice innovations, obviously in colonoscopy as well. And so I think most of us probably use one of the more viscous lifting solutions. So next up, I sort of had a nice conversation with Arvind Murali tonight. So he's from Bangalore Medical College, went to Cook County for his residency and did a GI transplant, GI and transplant hepatology fellowship at the University of Iowa. And we had a nice conversation tonight where he's got bold ambitions for hepatology and Orlando Health. And I think probably 3 years away from having a liver transplant service, which is really going to be fantastic in your ability to serve patients. So all the best with that, and teach us about liver diseases.
Excellent. Good evening, everyone. Thank you for being here today. Okay, so we will go over the liver slides before dinner is served, because we are mostly going to be talking about metabolic dysfunction associated steatotic liver disease. So first interesting study is on the prospective universal risk instrument. It is a novel precision diagnostic tool to accurately classify metabolic dysfunction associated steatotic liver disease with significant fibrosis. An estimated 30% of the general population are afflicted by MASLD. FIB4-based risk stratification showed a suboptimal clinical classification of MASLD patients. Authors hypothesized that integrating comorbidities into a patient assessment model will enhance the performance in classifying patients with MASLD. In order to test this, the authors aimed to develop a machine learning approach leveraging broadly available clinical data and to compare machine learning model with existing non-invasive tests or NITs. They used a prospective cohort of around 3,990 patients, veterans who underwent VCTE between January 2017 to June 2022. They used the MD Clone Adams platform, and patients with suspected MASLD were identified, and those with other etiologies, including alcohol, viral, and autoimmune, were excluded. For clinical prediction of significant fibrosis, which is greater than or equal to F2, the top 8 of 41 total universally available variables were identified by feature importance using a machine learning approach. Current NITs, including FIB4 index, APRI index, SAFE, and NAFLD fibrosis score, were computed for comparative predictive models. Liver stiffness greater than or equal to 8 kilopascal and greater than or equal to 10 kilopascal was used to classify stage F2 and F3 respectively. 13 machine learning models were tested to identify the least false negatives, and only models with recall of greater than or equal to 80% were evaluated based on accuracy, recall, area under the receiver operating curve, and F1 score. The cohort had 86% males, 54% were diabetics. The mean age was 59. A machine learning based prospective universal risk instrument was developed based on the random forest and the KNN algorithms and compared to existing NITs. PURI using the RF approach had the best performance with AUROC of 0.80 for greater than or equal to 8 kilopascal and 0.88 for greater than or equal to 10 kilopascal. And it performed 10 to 12 and 12 to 16 points higher than the closest SAFE and FIB4 based models respectively. If you look at the features that were explored to build this model, they used among all these variables, the variables that were included in the PURI model were age, hyperlipidemia diagnosis code or on a medication for hyperlipidemia, hypertension, obesity diagnosis code or BMI that is above or equal to 30, type 2 diabetes, ALT, AST, and platelet count. So all these are easily available variables and easily available laboratory markers. And if you look at this comparison of the PURI performance metrics against commonly used instruments, for PURI with the random forest, the area under the curve was 0.80. For FIB4, it was 0.68. For APRI, it was 0.67. For the SAFE, it was 0.70. And for NAFLD fibrosis score was 0.68. In conclusion, the prospective universal risk instrument is a novel approach to accurately classify fibrotic MASLD that outperforms current NIT-based models. PURI, just using readily available metabolic comorbidities and routine laboratory data, has broad clinical applicability even in resource-limited settings. It has the potential for advancing precision diagnostics beyond existing NITs in massive care. This I found as a very interesting study. This initiation of secondary SBP prophylaxis in patients with a new SBP is associated with a higher rate of non-SBP infections compared to those not started on SBP prophylaxis in a national cohort of veterans with cirrhosis. Antibiotic resistance and immune inflammatory changes affect the occurrence of infections in cirrhosis. Guidelines recommend secondary SBP prophylaxis for prior SBP. The authors aim to determine the impact of secondary SBP prophylaxis on infection development in a national cohort of veterans with cirrhosis and SBP. Using the VA corporate data warehouse, authors selected patients who had SBP using validated ICD codes between 2005 and 2019. Secondary SBP prophylaxis was defined as continuous ciprofloxacin or Bactrim use for greater than or equal to 120 days post-SBP with greater than or equal to 1 outpatient refill. Baseline data included demographics, cirrhosis severity, and Charlson comorbidity index. SBP recurrence and non-SBP infections such as C. diff, UTI, pneumonia, bacteremia, among others, were recorded for 2 years starting 30 days post-index SBP. The authors compared the odds of specific non-SBP infections between the two groups. I'm going to go with this flow chart here. If you look at this flow chart, they identified 5171 veterans with cirrhosis and index SBP, of which 58% were started on secondary SBP prophylaxis. 42% were not started on secondary SBP prophylaxis. If you look at the non-SBP infections, 39% was seen in patients who were started on prophylaxis as compared to 31% who were not started on prophylaxis, and this was statistically significant. And more interestingly, SBP recurrence was higher in patients who were on SBP prophylaxis at 22.5%, as compared to patients who were not on prophylaxis, which was 13.5%, which was also statistically significant. So in conclusion, in a national cohort of veterans, after their first SBP episode, secondary SBP prophylaxis was associated with a greater rate of SBP recurrence and non-SBP infections up to 2 years post-index episode versus those who were not given prophylaxis. Due to increasing antibiotic resistance and immunosuppression in cirrhosis, unnecessary and potentially ineffective antibiotic exposure needs to be reduced. Our next study is on SGLT2 inhibitors, which have been associated with reduced portal hypertension complications and mortality in patients with cirrhosis. Sodium glucose cotransporter 2 inhibitors are established first-line agents used for treatment of cardiovascular and metabolic associated diseases. However, data on their effects in cirrhosis, particularly regarding the complications of portal hypertension, remain limited. In this study, authors evaluated the impact of SGLT2 inhibitors on portal hypertension complications and mortality in patients with cirrhosis. They used the TriNext database, which included 66 US healthcare organizations. Authors examined patients aged greater than or equal to 18 years with cirrhosis who were treated with SGLT2 inhibitors from January 1, 2016 to November 30, 2024. Patients who had undergone liver transplantation were excluded. New diagnosis of ascites, SBP, hepatic encephalopathy, hepatorenal syndrome, variceal hemorrhage, and infection were specifically captured. Cirrhosis patients prescribed SGLT2 inhibitors were compared to those not receiving SGLT2 treatment. Over 637 patients were diagnosed with cirrhosis, and 6%, approximately 40,314 patients, were prescribed SGLT2 inhibitors. Following propensity score matching, each group consisted of 38,601 patients with cirrhosis. Among the groups, demographics, comorbidities, and components of MELD were similar. Beta blocker use was also similar in both groups, 66% versus 68%. Compared to patients not on SGLT2 inhibitors, patients who received SGLT2 inhibitors had significantly fewer portal hypertensive complications, including ascites, SBP, variceal bleeding, hepatic encephalopathy, and infection. And over a follow-up period of 8 years and 11 months, SGLT2 inhibitors group had a significantly lower all-cause mortality compared to those not prescribed SGLT2 inhibitors, 14% versus 32%, hazard ratio of 0.54, which was statistically significant. In conclusion, cirrhosis patients prescribed SGLT2 inhibitors appear to have decreased portal hypertensive complications and greater survival rates than those not receiving SGLT2 inhibitors. These data support the potential for integrating SGLT2 inhibitors into the treatment paradigm for portal hypertension and cirrhosis. Our next study is a systematic review and meta-analysis on comparing outcomes between early TIPS, which is within 72 hours, and standard therapy. Acute variceal bleeding is a common cause of death in advanced liver disease. Standard therapy for variceal bleeding is a combination of endoscopic therapy and vasoactive drugs, which have improved outcomes in these patients. Authors aim to assess whether early TIPS improve survival, incidence of rebleeding, new onset hepatic encephalopathy, new onset ascites in advanced cirrhosis patients. Authors systematically searched the Medline and MBase from inception till May 1, 2024. Early TIPS was defined in studies which included all patients who underwent TIPS treatment within 72 hours after endoscopic therapy. The outcome of interest was all-cause mortality. Secondary outcomes were 1-year survival, incidence of rebleeding, new onset hepatic encephalopathy, and new onset ascites. 9 randomized controlled trials were included with a total population of 689 participants, of which 369 received early TIPS and 320 received standard therapy. The early TIPS group included Child-Pugh Class A 20%, Child-Pugh Class B 34%, and 46% with Child-Pugh Class C, which was similar to the standard therapy group. There was no difference in comparing all-cause mortality between early TIPS and standard therapy. The odds ratio was 0.74, and the confidence interval was 0.5 to 1.09. However, compared to standard therapy, early TIPS group was associated with a lower risk of rebleeding, odds ratio of 0.20. It was not associated with an increased risk of hepatic encephalopathy, odds ratio is 1.31. And it was not associated with an increased risk of new or worsening ascites. At 1 year, survival was lower with the early TIPS group of 82.8% as compared to 70% in standard therapy. This study suggests that early TIPS significantly reduces the incidence of variceal rebleeding and improves 1 year survival rate, but was not associated with higher mortality or worsening hepatic encephalopathy. These findings will need to be validated with well-designed randomized controlled trials comparing early TIPS and non-early TIPS. Our next study is on the statin use in decompensated cirrhosis. Statin use in decompensated cirrhosis confers protection against portal vein thrombosis, hepatocellular carcinoma, and lowers overall mortality. Recent population-based studies have highlighted the benefits of statins in reducing liver disease progression, hepatocellular carcinoma, and liver-related mortality. However, their safety and efficacy in patients with decompensated cirrhosis remain unknown. And TriNext, which is a global federated cloud-based network research database comprising multiple healthcare organizations, was used. A total of 82 healthcare organizations were included for data extraction. Patients with decompensated cirrhosis between 18 to 75 years of age with or without statin use were identified by ICD codes, and they were compared after 1:1 propensity matching for demographics, hepatic disease, MELD score, and TIPS. Statin use was required for at least 6 months or longer based on medication refill data. The mean duration of follow-up was 5 years. The risk of occurrence of PVT, HCC, and mortality was assessed after the index event until completion of follow-up at 5 years. Index events were defined for both groups as meeting entry criteria, and in addition for the statin group as completing at least 6 months of confirmed statin use. After propensity matching, each group had 55,660 patients. The mean MELD 3.0 scores in the statin versus non-statin group was 16 each. Relative risk of portal vein thrombosis was lower in the statin group at 0.81. Relative risk of hepatocellular carcinoma was again lower in the statin group, 0.73. And mortality was also lower in the statin group at 0.75 at the end of follow-up. If you look at the freedom from cumulative event occurrence by Kaplan-Meier analysis at the end of follow-up at 5 years, for PVT was 96.4% versus 94.3% with a p-value of less than 0.01. For hepatocellular carcinoma, 97.4% versus 95.4%. Again, the p-value was less than 0.01. And for mortality was 64.4% versus 50.72%. So all parameters were favorable for statin use versus no statin use. This extensive real-world data reassures the safety of statin use in decompensated cirrhosis with a protective effect on portal vein thrombosis, hepatocellular carcinoma, and overall mortality. And freedom from all 3 events was favorable at the end of 5 years with at least 6 months of statin use. So the authors concluded that decompensated cirrhosis should not be a contraindication for statin use given the overwhelming beneficial effects as demonstrated in the study. And these are the Kaplan-Meier survival curves, and you can see for the overall mortality in figure 1C, patients on statins did better than those who were not on statins. Our next study is addressing the growing epidemic of obesity, bariatric surgery, or GLP-1 agonist in patients with MASLD. This was a retrospective cohort analysis over a 6-year period. GLP-1 receptor agonists have emerged as a promising alternative to bariatric surgery for managing obesity. Now, GLP-1 agonists, in addition to weight loss, confer benefits such as improved glycemic control in diabetes. So therefore, GLP-1 may play an important role in MASLD management. However, the long-term outcomes remain unknown. This was a retrospective cohort study using the TriNext database to compare long-term outcomes in patients with MASLD treated with either bariatric surgery or GLP-1 receptor agonist therapy. Patients with MASLD who were newly started on either GLP-1 RAs or who underwent bariatric surgery between 2015 and 2022 were included. The primary outcomes were the incidence of major adverse cardiovascular events or MACE and major adverse liver outcomes within 90 days and 3 years post-index event. Secondary outcomes included rates of incident myocardial infarction, stroke, acute heart failure, liver transplantation, hepatocellular carcinoma, decompensated cirrhosis, all-cause mortality, and all-cause hospitalization. Again, propensity score matching was performed to adjust for confounding variables, which included body mass index, comorbidities, malignant neoplasms, nicotine or alcohol use disorder, cardiovascular medications, vitamins, and insulin use. The study included 15,168 MASLD patients who underwent bariatric surgery and 12,170 patients treated with GLP-1 RAs. Patients with the bariatric surgery cohort had a median age of 46.2, and in the GLP cohort, the median age was 52.5. The mean BMI at the end of 3 years was 33 in the bariatric surgery group and 37.5 in the GLP RA groups. At 3 years, patients treated with GLP-1 experienced significantly lower rates of major adverse liver outcomes, 0.6% versus 1.2%. All-cause hospitalization was also lower in the GLP-1 group, and all-cause mortality was also lower in the GLP-1 group as compared to bariatric surgery. However, there was no significant difference in MACE rates between the two cohorts. The authors concluded that GLP-1 receptor agonists, when compared to bariatric surgery, were associated with lower major adverse liver outcomes and lower all-cause mortality rates in patients with MASLD, even when both cohorts were matched by BMI. This suggests that in patients who may not be surgical candidates or who prefer medical weight loss methods, GLP-1 agonists should be highly considered, although multi-center prospective studies are needed to validate the efficacy of this drug. Our next study is on therapeutic anticoagulation in cirrhosis, favors protection against decompensatory events, variceal bleeding, hepatic encephalopathy, and ascites, with no worsening of overall mortality, a real-world study from TriNext database. There is a lack of robust population-based evidence on the safety and outcomes of anticoagulation therapy in patients with cirrhosis. Short and long-term risks with anticoagulation use, such as esophageal variceal bleed, hepatic ascites, and hepatic encephalopathy, as well as the effect on overall mortality, are unknown. Again, TriNext is a research database comprising multiple healthcare organizations, and a total of 83 healthcare organizations were included in data extraction. Patients who were 18 to 75 years of age with cirrhosis on any long-term anticoagulation and a similar cohort of patients with cirrhosis not on anticoagulation were compared after a 1:1 propensity matching for demographics, hepatic disease, cardiovascular disease, placement and revision of tips, usage of beta blockers, and MELD score. The mean follow-up was 5 years, and the risk of hepatic decompensation events was assessed after the index event until the end of follow-up of 5 years. The index event was defined as cohort subjects meeting entry criteria, and for the group using anticoagulation is at least 6 months of anticoagulation use. After propensity matching, each group had around 13,129 patients. Mean MELD was 16 and 17 respectively between the two groups. Relative risk of esophageal variceal bleed occurrence was lower in the anticoagulation group. Also for ascites, it was lower in the anticoagulation group. For mortality was slightly higher in the anticoagulation group in cirrhotic patients versus no anticoagulation use. But if you look at the 5-year Kaplan-Meier analysis of cumulative events, for freedom from esophageal variceal bleed, 97.8% of patients on anticoagulation had, as compared to 92.7%, did not have esophageal variceal bleed. For ascites, 75.5% on anticoagulation, as compared to 71.1% did not have ascites. And if you look at the mortality, it was 61.1% in patients on anticoagulation and 62.1% in patients without anticoagulation, and there was no statistically significant difference at 5 years. Anticoagulation in patients with cirrhosis is safe. It reduces the risk of decompensatory events, including esophageal variceal bleed, hepatic encephalopathy, and ascites. Protection against multiple decompensatory events is observed with at least 6 months of anticoagulation therapy, with no detrimental effect on overall 5-year survival. Anticoagulant use in cirrhosis conferred a protective effect against decompensatory events lasting 5 years. Although there was a marginally increased relative risk of overall mortality, the 5-year survival was not statistically different between the two groups. So the take-home messages from the abstracts: prospective universal risk instrument is a novel approach to classify fibrotic MASLD that outperforms current NIT-based models. Secondary SBP prophylaxis may be associated with a greater rate of SBP recurrence and non-SBP infections up to 2 years post-index episode versus those who were not given prophylaxis. Cirrhosis patients prescribed SGLT2 inhibitors, they appear to have decreased portal hypertensive complications and greater survival rates than those not receiving SGLT2 inhibitors. Early tips significantly reduces incidence of variceal bleeding and may improve 1-year survival rate, though no significant difference in all-cause mortality was noted as compared to standard therapy. Extensive real-world data seem to reassure the safety of statin use in decompensated cirrhosis with a protective effect on portal vein thrombosis, hepatocellular carcinoma, and overall mortality. Freedom from all 3 events were favorable at the end of 5 years with at least 6 months of statin use. GLP-1 receptor agonists, when compared to bariatric surgery, seem to be associated with lower major adverse liver outcomes and lower all-cause mortality rates in patients with MASLD, even when both cohorts were matched by body mass index. And finally, anticoagulation in patients with cirrhosis is safe, likely reduces the risk of decompensatory events, including variceal bleed. Protection against multiple decompensatory events is observed with at least 6 months of anticoagulation therapy with no detrimental effect on overall 5-year survival. Thank you very much.
Thank you very much. That was excellent. I think the GLP-1 receptor agonists, once again, are showing their value even outside of weight loss and diabetes. Clearly, they're a drug to treat MASLD. People are using them potentially for menopause and so on and so forth. So clearly very powerful. I think we heard from the combination of that lecture and G's lecture that endohepatology is now prime time. Its ability to get adequate tissue acquisition as well as restratify patients with cirrhosis and portal hypertension is very important. And I think it's here now. Also, I think these abstracts also taught us that hepatology is actually very complex, particularly MASLD. It's not just about losing weight. There's far more to it. And I sort of, myself and others in this space, I think we should really refer to a hepatologist earlier than perhaps we would normally do in the past. And I think there's a lot of these risk assessment tools that are being available, and that PURI risk assessment was a nice example. And I suspect they're going to be embedded in our EHR as a standard of practice. So as soon as that patient's you open their chart, Epic or otherwise, we're going to see these risk assessments, and they'll help us sort of restratify care. And so next we're moving to IBD, and we've got Mitali Agarwal who will be educating us. She's from Florida State University in Tallahassee, did her residency in UF Gainesville, fellowship in Illinois, in Chicago, and did an IBD fellowship at the Cleveland Clinic. So I know now you're an attending physician at the IBD Center along with Uday. So please come and tell us about IBD.
Thank you so much for coming and listening to the IBD portion. I'd like to thank Dr. V for inviting me back here to speak. This is my 3rd year, and I think the abstracts this year are particularly good. So stay tuned. So I'm excited to present this first study. It was written and performed by my former program director at Cleveland Clinic for IBD, Dr. Florian Reeder. This is a phase 2A randomized placebo-controlled double-blind study to assess the safety, pharmacokinetics, pharmacodynamics of AGMB-129 in patients with fibrostenotic Crohn's disease. Interim results from the STANOVA trial. So according to the abstract, AGMB-129 is an oral GI-restricted actin receptor-like kinase 5 molecule inhibitor developed for the treatment of fibrostenotic Crohn's disease. Patients with symptomatic fibrostenotic Crohn's disease were randomized in a 1:1:1 ratio to receive AGMB-129 200 milligrams BID, AGMB-129 100 milligrams QD, or placebo for 12 weeks. Primary objectives were safety and tolerability of AGMB-129. Secondary objectives were to evaluate the plasma PK and changes in gene expression in ileal biopsies collected at screening and at week 12. 41 subjects with a mean disease duration of 18 years and a mean CDAI score of 142 were included in the study, and 73% of these patients were on biologic therapy. The study found that AGMB-129 was safe and well tolerated without cardiac toxicities or other adverse events. Mucosal ileal biopsies revealed downregulation of fibrotic and inflammatory gene sets and improved symptom severity and disease activities. So the authors concluded that AGMB-129 may become a novel treatment for fibrostenotic Crohn's disease, and it is safe and well tolerated with significant downregulation of both inflammatory and fibrotic pathways and improvement in symptom and endoscopic outcomes. The next study is a biomarker-informed guidance improved outcomes of anti-TNF treatment in patients with IBD in a multi-center randomized open-label prospective clinical trial. The response to anti-TNF therapy varies among patients, as we all know. The aim of this study was to assess the efficacy of biomarker-informed therapy decisions by comparing guidance through molecular therapy board to standard medical care in patients with active IBD initiating anti-TNF therapy. So adults with IBD who would receive for the first time anti-TNF therapy such as infliximab were randomized to either molecular medicine care or the standard best care. And data on mRNA-based biomarkers along with infliximab and anti-drug antibody levels was provided for the molecular medicine group at various time points, while data for best care group was not provided. Primary endpoint was disease at week 52, endoscopic remission, and biochemical remission. 87 patients completed the study. Disease control, endoscopic and clinical remission was significantly more frequent in molecular medicine group at week 52 compared to the best care group. Thus, the authors concluded that molecular guidance significantly improved therapy outcomes with higher proportion of patients achieving disease control compared to standard best care. These findings support that integration of molecular medicine approaches in therapy boards to optimize treatment strategies in patients with IBD. The next study is long-term infant outcomes in the pregnancy and inflammatory bowel disease and neonatal outcome, the PIANO study. The authors in the studies assessed outcomes in offsprings exposed to in utero biologics for serious infections, congenital abnormalities, development issues for at least 4 years after birth. Offsprings exposed to anti-TNF therapy, vedolizumab, ustekinumab, immunomodulators, or combination therapy were compared to offsprings who were not exposed to any therapy. 438 live offsprings were included in the study. The study found that higher percentage of mothers with ulcerative colitis had biologic exposure and more steroid exposure compared to mothers with Crohn's disease. Those on anti-TNF and thiopurine combination therapy had significantly lower rates of active disease during pregnancy compared to those on no advanced therapy. Rates of serious infection by age 4 were comparable across drug classes, and preterm birth was associated with significantly higher rates of serious infections. Congenital malformation and developmental milestones were comparable between the biologic exposed group versus the non-biologic exposed group. Thus, the authors concluded that childhood outcomes are comparable in biologic exposed and unexposed infants born to mothers with IBD, supporting the use of these medicines throughout pregnancy to help maintain maternal health. The next study is titled Impact of Age on Efficacy and Safety of Advanced Therapies in Ulcerative Colitis, a pooled analysis of randomized controlled trial. The aim of the study was to assess whether age modifies treatment efficacy and safety of advanced therapies for ulcerative colitis during an induction period of weeks 0 to 6. The study was performed using pooled analysis of 10 randomized controlled trials of advanced therapies, including anti-TNF, vedolizumab, ustekinumab, and tofacitinib in patients with moderate to severe ulcerative colitis. Efficacy was defined as primary outcome of clinical remission and secondary outcome of induction of endoscopic improvement, endoscopic remission, and symptomatic remission. Safety was defined as serious adverse events, including infection. Efficacy and safety in different advanced therapies was compared in patients greater than or equal to 60 years versus less than 60 years. A total of 6,192 patients were included, out of which 634 patients were over the age of 60. Efficacy and safety outcomes were similar with advanced therapies over placebo in both older versus younger adults. Thus, the authors concluded that advanced therapies demonstrate similar efficacy and safety across people with ulcerative colitis over and under the age of 60. These findings support the use of advanced therapies in older adults with ulcerative colitis. This next study from Dr. Bo Shen, titled Randomized Controlled Trial Comparing Endoscopic Balloon Dilation versus Endoscopic Stricturotomy for Short Strictures Less than 3 centimeters related to Crohn's disease, aimed to compare the efficacy and safety of endoscopic balloon dilation versus endoscopic stricturotomy in managing Crohn's-related strictures. Crohn's disease patients with fibrotic or mixed fibrotic and inflammatory strictures that were less than 3 centimeters in length were randomized to get endoscopic balloon dilation versus endoscopic stricturotomy. The main outcomes were reintervention rates, subsequent surgery, adverse events, stricture-related ER visits, and hospitalization. 41 patients were in the study, out of which 21 received endoscopic balloon dilation and 20 received endoscopic stricturotomy. Reintervention rates and need for subsequent surgery was higher in the endoscopic balloon dilation compared to endoscopic stricturotomy. Stricture-related ER visits and hospitalization and adverse events was not statistically different between the two groups. Thus, the authors concluded that the endoscopic stricturotomy is associated with lower reintervention rates and need for subsequent surgery compared to endoscopic balloon dilation for patients with short segment Crohn's-related strictures with a similar safety profile. Our next study is titled A Risk Stratification Algorithm to Predict Relapse During IV to Subcutaneous Switching of Infliximab in Patients with IBD. So now, for about the past 2 years, subcutaneous infliximab has been approved, which is great for patients because it is a lot easier to administer than going to an infusion center and getting it through an IV. So the aim of this study was to investigate predictors of relapse upon switching from IV to sub-Q infliximab. And relapse was defined as a Mayo score greater than 2, Harvey-Bradshaw greater than 4, or an increase in fecal calprotectin greater than or equal to 150. 98 patients were in the study, out of which 14 relapsed. The study found that baseline infliximab clearance and baseline fecal calprotectin were identified as independent predictors of relapse after switching from IV to sub-Q infliximab therapy. And our last study is efficacy and safety of autologous hematopoietic stem cell transplantation in refractory Crohn's disease. This is pretty cool. The aim of this study was to report long-term clinical and safety outcomes of hematopoietic stem cell transplantation for patients with refractory Crohn's disease. 100 patients with refractory Crohn's disease from 3 international centers underwent stem cell transplantation. Clinical and endoscopic evaluation at baseline and last documented follow-up after transplant for 68 patients were reviewed. Additional outcomes were new initiation of advanced therapy, IBD-related surgery, need for parenteral nutrition, hospitalization, and death. At median 2-year follow-up, 75% of the patients had endoscopic improvement. 46% of the patients did not require advanced therapies. Of the patients that required advanced therapy, 84% required only a single therapy. Seven Crohn's-related surgeries were performed, out of which 2 were ileostomy reversals. No patients progressed to bowel failure. No long-term complications were noted, including hospitalization, renal failure, death, or malignancy. Thus, hematopoietic stem cell transplantation holds promise as a future therapy for patients with highly refractory Crohn's disease. So we'll finish off today with take-home messages from the IBD portion. So treatment using GI-restricted actin receptor-like kinase 5 small molecule was safe and well-tolerated in fibrostenotic Crohn's disease, with significant downregulation of both inflammatory and fibrotic pathways, with trends of improvement in symptom and endoscopic measures. Molecular guidance significantly improves anti-TNF therapy outcome in patients with IBD, with higher proportion of patients achieving disease control compared to the standard best care. Outcomes for children 4 to 16 years of age are comparable, whether their mother with IBD was exposed to biologic or not, supporting the use of these medications throughout pregnancy to support the maternal health. Also, advanced therapies demonstrated similar efficacy and safety across people with ulcerative colitis over and under the age of 60 years old. Endoscopic stricturotomy demonstrated significantly lower reintervention rates and need for subsequent surgeries when compared to endoscopic balloon dilation for short segment, less than 3 centimeter Crohn's disease strictures, and has a similar safety profile. Baseline infliximab clearance and fecal calprotectin are accurate and independent predictors of relapse when switching from IV to subcutaneous infliximab therapy. And lastly, hematopoietic stem cell transplantation may hold future promise as a rescue therapy for patients with highly refractory Crohn's disease. Thank you.
Thank you, Mitali, and good evening, everybody, for who is here and online. I just tried to summarize the IBD section of the abstracts. I think the first thing I would classify the abstracts into endoscopic fibrostenotic disease. So fibrostenotic Crohn's is one of the biggest issues we see with Crohn's patients, and in that we have 2 abstracts. One is the role of ALK5 receptor kinase and the role for decreasing fibrosis. It's a proof of concept study, very early. But I think there's some promise. There's one more in phase 3 trial, which is anti-TLA1, which actually has much more promise as well. So in the future, we'll see more of the anti-fibrotic therapies in the management of Crohn's disease. This will be used in addition to a biologic sometimes in managing strictures in Crohn's. The other section of endoscopic stricturotomy is an option. I think it's a cool option. We do it routinely in our patients. But selecting the right patient is important. In this trial, they included both basically anastomotic strictures and de novo strictures. Sometimes, de novo strictures don't do well with the endoscopic stricturotomy compared to a balloon dilation. So that's why you see the time to event outcomes were not much different between those 2 things. So if we select the right patient for ES, it's probably the best therapy available. But I would prefer it, at least in our center, to patient with anastomotic strictures, not the de novo strictures. In the section on medical management, 2 things very important. I think the importance of continuing the medication throughout pregnancy. Again and again, the piano registry has shown the importance of safety and long-term outcomes in infants born exposed to biologics. So reinforcing that you should continue the drugs throughout pregnancy is probably the important take-home message from that trial. And the efficacy of safety and of biologics in older patients has always been a concern in Florida. At least we see a lot of older patients with IBD. And I think multiple studies, including this study, has shown that the efficacy of advanced therapy and the safety is excellent for older people. So you should not hold therapy just because of the age. I think if they need the treatment, they should get the treatment. The other section is on biomarkers. We know biomarkers have changed the way we approach IBD. So prospective drug level assessment using a molecular biomarkers are going to be the future in the management of IBD. And I think both the studies from Europe have shown that they have been very useful for treatment. So I think in the future, we're going to see a lot more practically available advanced molecular techniques in the next 5 years or so. The last section is on HSTCT, stem cell transplant. this should be taken with very, very cautionarily, because a lot of randomized control trials have not shown that these are actually more safer in patients with refractory Crohn's disease. This is not a randomized control. This is a prospective long-term outcome data. So the studies in the past have not shown the safety because of high risk of acute GVHD, graft-versus-host disease, high risk infections, even death. So this should be reserved. Take-home message is very, very refractory Crohn's section, those patients in clinical trials in a big center, not anywhere else. So I think this is very early. I think we are a few years away from routinely using HST, CT in Crohn's patients, even for refractory Crohn's patients at this point of time. And this is my take-home message from all the slides we saw today. Thank you so much. Yeah.
Thank you so much. Shyam wouldn't allow me to give an editorial on IBD. As he said, I don't know anything about it. So it is very true. So I think today was very important. And I hope it sort of gives you a sense of how much is changing and how quickly. I'm not sure if you're aware, but up until 1950, the doubling time for medical knowledge was 50 years. So every 50 years, the total world of medical knowledge doubled. Any guesses as to what it is today? How long it takes for medical knowledge to double? 2 months. 2 months. And so I think it tells you about obviously being part of these events, but also having access to your own mechanisms to keep yourself in the know is really important. And I'm not sure if people use open evidence or these other large language models such as ChatGPT or Gemini, but certainly, don't feel that you're inferior by running to this. It's just impossible for us to keep up to date with our knowledge. So I'll just hand over to Shyam to close, but thanks everyone.
We are sharp on time at 7:30, and we are supposed to close at 7:30. I want to thank my colleagues. I think I'm blessed with a fantastic pool of specialists and gastroenterologists in the Digestive Health Institute. I look at them and I say, everybody is a fantastic physician, and I'm so proud of each of them. So thanks to Dr. Nathoo, Dr. Bang, Dr. Agarwal, and Dr. Murali for speaking today. And my sincere thanks to Vivek. Vivek is not a member of the Digestive Health Institute, but he's a part of our family. He comes for all our events, and I'm really, really proud of his accomplishments. And finally, for all of you from around the world who are joining us today, I think I just did a Google search on where you're from Nigeria and Singapore and South Africa and Nepal and Kuwait and Australia, India, Venezuela, Brazil, Japan, Colombia, Mexico, and Canada. And in the US, we have the highest delegates from California, actually. Maybe you guys are more awake than others, and from New York and Tennessee. But we will meet again next year. But thanks again for joining. And finally, I want to thank Olympus for your sponsorship of this event, without which it's not possible. So thanks again, and good night. You guys need to go to sleep in other parts of the world. Thank you.